Hi, welcome back to our next section, which is vertigo, dizziness, and headaches. Now, vertigo means that you have a sensation of the room is actually physically spinning around you. Remember that when somebody says that they are quote-unquote dizzy, dizzy does not have a specific medical meaning. Dizzy does not have a direct meaning for what is the etiology of dizzy. Dizzy can mean that someone is vertiginous. Vertiginous means that literally the person feels that they are standing still and the room is spinning suddenly around them. Okay, but however, dizzy can also mean someone who is light-headed. Now, many people, when they come in and say that they're dizzy, in fact, the most common reason that people feel that they're dizzy, in fact, that they're saying that they're lightheaded. In other words, the biggest difference between vertigo and lightheadedness is that lightheadedness is a sign of cardiac insufficiency. This is usually a perfusion problem. This is a pump function problem. This is, I'm not pumping enough blood into my head so that I'm getting lightheaded. I feel like I'm going to pass out. That term is sometimes called pre-syncope. Now, this word pre-syncope means I feel like I'm going to have syncope, but I don't actually lose consciousness. The evaluation of pre-syncope or lightheadedness is really the same as the evaluation of syncope, same etiologies. Now, dizzy could also mean someone who's had a stroke. Someone who's had a stroke and someone who is weak. I once was called to evaluate a patient. They said the patient was dizzy. They were dizzy. Well, the guy had a stroke, and every time they stood him up, he fell over to one side because his leg was paralyzed. So they said he must be dizzy because every time he gets up, he looks like he's wobbling. No, his left leg had flaccid paralysis. Weakness. The other thing about this dizziness thing, it could be cerebellar problems. Cerebellar problems result in dizzy because when you get up and you have a cerebellar problem and you're rocking and they call titubation here, wicking and twicking and breakdancing while standing up, that could be a cerebellar problem where you've lost proprioception. So when you say the word dizzy, the next word should always be, did you mean lightheaded? Did you mean vertiginous? Did you mean weak? Did you mean cerebellar problems? When the patient says dizzy, your next question always has to be, did you feel the room spinning around you? Or did you feel lightheaded, like you wanted to pass out? Doc, I feel dizzy. Well, when you say dizzy, what do you mean by that? Well, dizzy. Well, are you literally feeling like the room is turning around you or spinning around you? Or do you mean really that what you feel is that you feel lightheaded, like you're browning out? Which one is it? So that's the whole issue. Let's look at our slide here. Remember that the most important thing about vertigo is quote-unquote spinning. In other words, the room literally feels to the person that it is moving. And that is always a neurological problem. Now, pre-syncope, as we said, is generally speaking a cardiac problem, and the evaluation is the same thing that we said in all the evaluation of syncope, which is this a rhythm problem? Is this a cardiac obstructive problem? Is this a rhythm problem? Is this a cardiac obstructive problem? Is this a rhythm problem? Is this a cardiac obstructive problem? In terms of what we mean. Now, our next issue here is when somebody says, yes, doc, in reality, the person is feeling vertiginous. Well, I'm dizzy, but I really meant to say that I'm feeling vertiginous. Okay. Now, once you've made the determination that there's vertigo, they are going to make the determination, is that vertigo, well, is it central vertigo? Or is it peripheral vertigo? Now, which is more common? Central vertigo or peripheral vertigo? Which is more common? And the answer is peripheral by far. 4 to 1, 5 to 1, 5 to 1. Minimum 5 to 1. Minimum 5 to 1, okay? Peripheral vertigo is 80 to 90% of vertigo. Central vertigo is inside the CNS. Peripheral vertigo means the 8th cranial nerve or the inner ear. 8th cranial nerve or inner ear. Peripheral vertigo means basically it's the 8th cranial nerve or the inner ear, inside the ear, the 8th cranial nerve, once it actually leaves the brainstem. So there's two things about it. One is etiology. Well, central vertigo is almost some form of stroke. Central vertigo is some form of stroke. multiple sclerosis, cerebellar tumor, stroke, some form of trauma or bleeding or stroke that is infarcting that part of the cerebellum or the part of the brain that controls the eighth cranial nerve or inside the cerebellum. Now, there can also be drug toxicity. For instance, phenytoin toxicity very prominently presents with nystagmus and the sensation of vertigo. Phenytoin toxicity presents with nystagmus and ataxia and vertigo. Nystagmus, ataxia, and vertigo. Dilantin, phenytoin toxicity presents with nystagmus, ataxia, and vertigo. So, peripheral vertigo is eighth cranial nerve problems, problems inside the ear, problems inside the tympanic membrane, problems inside mostly the cochlea and the vestibular system. Now, central vertigo, here's the biggest difference. You ready? Peripheral vertigos are associated with hearing loss and tinnitus. This is the single biggest and the fastest way to distinguish between central and peripheral problems. This is the single biggest way to distinguish between central and peripheral problems. Peripheral problems are associated with hearing loss and with tinnitus. Peripheral problems are associated with hearing loss and tinnitus. The things that go inside the cerebellum is not perceiving hearing. This is not perceiving hearing. That's the biggest deal. No hearing loss in these. The other thing is peripheral vertigo is associated with a nystagmus, that with the nystagmus, all forms of peripheral vertigo, over time, the nystagmus stops when you're looking at something. You see, at the beginning, everybody can have a couple of beats of nystagmus. Oh, let's look at my finger. And it stops. People have peripheral vertigo problems and nystagmus. It will go longer, and then eventually stops. But central problems won't stop. The nystagmus will never stop. That's called that it won't extinguish. Extinguishment means that the vertigo and the nystagmus stops. The nystagmus stops over time. And the other thing is that peripheral vertigo is hearing loss, tinnitus, nystagmus that will extinguish over time. And this has a more rotatory component to it. That has a more circular and rotatory component. Let's look at the next slide. Now the issue is here, as we look at this, is that central vertigo, although it may be gradual, that's the least important thing because you could have a sudden stroke. However, this is the biggest thing, is talking about the difference between hearing loss, tinnitus, and hearing loss between the central and the peripheral problem. Neighborhood signs. Neighborhood signs here. That's an interesting term. Nowhere else in medicine do we use the word neighborhood signs. It's like whether it's the people next door to you put their garbage out or something like that. Neighborhood signs. Neighborhood signs, in one nutshell, means this. Central vertigo has focal neurological findings. Central vertigo has focal neurological findings. Central vertigo has focal neurological findings. In other words, people who are weak, people who are numb, people who are weak and people who are numb, in other words, that they've had a stroke. They've had a stroke. And this is the other thing. See where it says does not suppress with fixation? Does not suppress with fixation. Does not suppress with fixation means that it has an issue where over time it will not stop. Suppress with fixation means, look at my finger. I'm looking at my finger. Central vertigo, even though you're looking at one object, won't stop. You'll continue to have that nystagmus. You'll continue to have that nystagmus even though I'm looking at one thing. Peripheral problems will have nystagmus, doink, 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 and will stop over time. The other thing is, one of the ways that you tell that someone has phenytoin toxicity is that when the mild toxicity occurs, you have horizontal nystagmus at mild toxicity. At mild toxicity, you have horizontal nystagmus. You have horizontal, boinka, 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 at mild toxicity. At more severe toxicity, you have vertical. the vertical toxicity, vertical for severe toxicity. As the level goes higher, people look up. It's vertical. As the level goes higher, they start looking up. Horizontal nystagmus, no big deal. Vertical nystagmus, up and down, that's a big deal. That's a big deal. Now, remember also is that these people have ataxia and there is no therapy for phenytoin toxicity, but this is the biggest point on phenytoin toxicity. Vertical nystagmus horizontal nystagmus at mild toxicities and vertical nystagmus at severe toxicities. Okay. You have a person who's coming in because they're dizzy. Ay, Dios mío. Ay, yo tengo mareo. Ay, doctor. Ay, catch me, I'm falling. Catch me, I'm falling. Hey. Okay. So, when the person feels dizzy, now, the first thing is this. Do you feel lightheaded? No, I don't feel lightheaded. I feel vertiginous. Ay. Canta y no llores. So I've determined that in fact I have vertigo. Okay, you have vertigo. The next step is it central or peripheral? Central problems, they're usually more obvious. Why? The person's focal, the person's had a stroke, they have multiple sclerosis, they have phenytoin toxicity, they've got some reason for it. And then of course the nose suppression and the multidirectional nystagmus. Okay, I have peripheral, this is far more common anyway. Matter of fact, you can go to peripheral most of the time, just because it's far, far, far more common. Now, peripheral nystagmus. I can go to peripheral nystagmus here, and what it is that I can say, okay, well, the most benign would be benign positional vertigo. Benign positional vertigo. Benign positional vertigo gets distinguished from all the other forms of vertigo for two simple reasons. The word benign positional, benign means no tinnitus, no hearing loss, no tinnitus, no hearing loss. So benign positional vertigo, no tinnitus, no hearing loss, just vertigo. Just vertigo. Just vertigo. That's it. That's it. Only vertigo. Vertigo only. Now that's the only one that is vertigo only. And the other thing is this. Meniere's disease does not give you vertigo only on standing up. Labyrinthitis does not give you vertigo only on standing up. Acoustic neuroma, a tumor on my 8th cranial nerve. Acoustic neuroma does not give it to you only when you're standing up, because you know what? It's not like I get an acoustic neuroma only when I stand up. Oh, I'm lying flat, I'm okay. Oh, I stood up. Oh, I got a tumor on my nerve. You have an acoustic neuroma whether you're up or down. Labyrinthitis and Meniere's disease. Labyrinthitis and Meniere's disease happen whether you are up or down. It's not only when you're lying flat and then you get up. Okay? A perilymph fistula. A perilymph fistula is not happening only when you get up. You have a perilymph fistula whether you're up or down, whether you're up or down. So the thing here is that benign positional vertigo, first of all, has no other problems except vertigo. No other problems except vertigo. And it's the only one in which it's exclusively when you go from a sitting to a standing position. From a lying to a standing position. When you start lying, then you stand up, then you get the problem. When you lie down and you stand up, that's it. Only vertigo. Now, that's to distinguish it from labyrinthitis and Meniere's disease. Labyrinthitis and Meniere's disease, both of these get hearing loss. Both of these can get hearing loss. They both get hearing loss. These both give tinnitus. They both give tinnitus. Well, what is going to be the difference then between labyrinthitis and a Meniere's disease? Labyrinthitis is going to usually be a single episode, and somebody's going to have a recent viral illness. A recent viral illness and a single episode. Meniere's disease tends to be short duration recurrent symptoms. Short duration and recurrent. Therefore, it's more long-term disease. They both give, everything here gives vertigo. Everything here gives nystagmus. If it says vertigo, vertigo and nystagmus essentially are almost identical. Every time you see vertigo, you also see nystagmus. Every time you see nystagmus, you also see vertigo. Vertigo and nystagmus are interchangeable. Vertigo and nystagmus are also interchangeable. I said vertigo, it says nystagmus. Nystagmus and vertigo, hearing loss, tinnitus. Both of these, single episode, labyrinthitis, multiple recurrent short episodes, Meniere's disease. Well, perilymph fistula can also give you a hearing problem. Oh, but so can acoustic neuroma. They get a hearing loss problem, Well, what's going to be different about the perilymphatic fistula? What will be different? And the answer is the single most important thing about a perilymph fistula, which may or may not give you tinnitus, is that the perilymph fistula is associated with the history. In the history they tell you, in the history they tell you, in the history they tell you, trauma. Trauma to the ear. Trauma to the ear. You're a smaller person being attacked by a bigger person, take your hands, boom, boom. Oh, wise guy. So, box their ears. Boy, barrow trauma to the ears, man. Barrow trauma to the ears will screw you up. That will cause you to rupture the tympanic membrane, damage that tympanic membrane, and you can get a perilymph fistula chronically. Now, what's different about an acoustic neuroma? Acoustic neuroma is basically a schwannoma, or a tumor of your eighth cranial nerve. It's a tumor of your eighth cranial nerve. What's different about an acoustic neuroma from all the others? What is different from an acoustic neuroma from all the other things? The acoustic neuroma has ataxia. You see, there is a difference between just vertigo, the room is spinning, and finger to nose abnormal, heel to shin abnormal, Romberg makes me fall over. Oh, I can't do my walking. Dun, 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 dun. I can't do my walking because I wobble over. And acoustic neuromas give you ataxia. And that's the difference. Let's look at our next slide. And this is telling us here, well, Meniere's disease. Always like it. Sounds like butter sauce, you know? So, Meniere's disease, tinnitus, hearing loss, and vertigo. Oh, well, labyrinthitis. Look at this. Tinnitus, hearing loss, and vertigo. So, Meniere's and labyrinthitis say the same thing. Except this one is sudden, lasts longer, but labyrinthitis is a single episode that lasts longer. Meniere's is multiple episodes that last shorter. Labyrinthitis, single episode, but the single episode lasts longer. Meniere's, multiple recurrent episodes that last shorter with each episode. Benign positional vertigo or benign paroxysmal vertigo is something that only happens when you change position and has no other associated symptoms. Now, central vertigo, it says here, a tumor, a stroke, ischemia, multiple sclerosis. And remember, the drug toxicity or overdose we're talking about the most frequently is phenytoin toxicity. Phenytoin toxicity. Now, what is going to be the treatments of all of these? Well, anytime you see vertigo, it's always okay to say meclizine. Meclizine is a kind of antihistamine that decreases the production of endolymph. Meclizine is a drug that we don't really know how it works, honestly, but it's good for all dizziness in general, meclizine. Antihistamines are also good, and if people are vomiting, the 5-hydroxytryptamine inhibitors, such as ondansetron, can be useful if it's very, very, very severe. However, meclizine is useful for almost all people with vertigo and who have dizziness. It's a dizziness vertigo drug in general. Now, benign positional vertigo, it's like kidney stones inside your ear. Benign positional vertigo. It's like kidney stones inside your ear. Benign positional vertigo. You have a person and there's otoliths. And the otoliths, the ear stones, get stuck on the cells inside the 3 semicircular canals inside the ear. And there are maneuvers to maneuver and position the head around in between episodes to try and fix it by head reposition and to dislodge those otoliths, those otoliths. Meclizine for labyrinthitis, because it's going to get better any time. It's going to get better. It's going to get better over time. So it will resolve on its own. This is kind of like what you might call otitis interna in a way. It's a viral infection of your inner ear. It's a virus of your inner ear. Meniere's disease is different. Meniere's is the overproduction of endolymphatic fluid inside the ear. It is the overproduction of endolymphatic fluid inside the ear. It is the overproduction, salt restrict, of endolymphatic fluid and diuretics. It is the overproduction of endolymphatic fluid inside the ear. Meniere's disease, salt restriction and diuretics. Salt restriction and diuretics over time. Now, perilymph fistula, you can do a surgical repair, might close over time, and acoustic neuromas have to be treated with surgical resection. Also remember that acoustic neuroma has a special diagnostic test different from the others, and that is a CT scan to look into CT or MRI to look for that tumor. Let's look at the next slide here. Vertigo. Well, what's the treatment? Based on etiology, that's true. But you'll also see meclizine no matter what. Diazepam takes your mind off of it. If you're overproducing fluid, if you're overproducing endolymphatic fluid, low salt and diuretics, this is in a little way of thinking that Meniere's disease is kind of like glaucoma of your ear. It's kind of like ear glaucoma, which is to say you use medical therapy to try and decrease the pressure, and if that doesn't work, you surgically poke a hole in things. Now, benign positional vertigo, we said that there are otoliths, stones in the ear. Positional maneuvers to dislodge them is because this might actually cure the disease, cure the disorder by flipping the head around a little. Now, Meniere's disease, low salt and diuretics to decrease endolymph. If it doesn't work, surgically place a hole. The same way in glaucoma. We would use acetazolamide to decrease the production of the aqueous humor. Beta blockers and pilocarpine to constrict the eye. But if beta blockers and pilocarpine to constrict the eye and acetazolamide to decrease the production of aqueous humor does not work, then in glaucoma we're going to do a surgical iridotomy, poke a hole in the iris with surgery. The same thing with Meniere's disease. Salt restriction and diuretics, and if that doesn't work, surgically place a hole. Now, that is the end of our vertigo section, but the most important thing is this. Ready? Patients don't come in and say, I feel vertiginous, okay? Oh, yes, I was watching an Alfred Hitchcock movie, and I decided that I have vertigo. Well, that also means, no, people say, hi, I have dizziness. I feel dizzy. Well, what do you mean by dizzy? Do you mean that you feel lightheaded, as if you're going to pass out and the room is becoming brown and you need to sit down? Do you feel that you have the room spinning around you? Oh, I have the room spinning around you. Okay, everything that gives vertigo also gives nystagmus, because when the room is spinning around you, your eye is adjusting with nystagmus. Fine. Central causes of nystagmus and vertigo, multiple sclerosis, strokes, drug toxicities, are associated with neighborhood findings, such as other focal neurologic deficits, ocular findings, dysarthria, diplopia, ocular problems. And central vertigo does not give hearing loss and tinnitus. Hearing loss and tinnitus. Hearing loss and tinnitus is a feature of peripheral vertigo, all of them except benign positional vertigo. Hearing loss and tinnitus, ringing in the ears, is a feature of all of them except benign positional vertigo. Labyrinthitis is like an acute form of Meniere's. You might say, well, then on the first episode, how do I know whether it's Meniere's or labyrinthitis? And the answer is, you don't. But then again, neither do I. So that means we'll all have to fail together if they ask you, because I don't know either. A child comes to me with hands full saying, what is the grass? How can I answer the child? I do not know any more than he. A person comes to you with labyrinthitis or the first episode of Meniere's and say, I'm feeling dizzy and vertiginous. How do I know whether it's an episode of labyrinthitis or the first episode of Meniere's? I don't know. I don't know. But I do know that we get something unique about each one. Only one has trauma, only one has ataxia, only one is recurrent with multiple episodes. Thank you very much, thank you very much, thank you very much.